these are disorders that occur in pregnancy which are characterized by persistently high blood pressure of greater than or equal to 140 over 90 millimeters of mercury. So this measurement of above 140 over 90, it has to be persistent. Not you just make one reading, then you conclude that this person is hypertensive or this person has a hypertensive disorders. So you have to do at least minimum of 3 readings and on separate intervals. That is like 4 hours apart. If you've done a reading, let's say at 8 hours, you find it's above 140 over 90. You do another one 4 hours later, you find again it's above 140 over 90. Then you do another one maybe 4 hours later, you find again it's high. Then you can conclude to say this person has hypertension or a hypertensive disorder in pregnancy. So now the types, there's chronic hypertension, which can occur in pregnancy. Then there's gestational hypertension. I'm just listing them for now. And then there's preeclampsia. This is look at hypertensive disorders in pregnancy. So the outline of my presentation, I'll start with the definition, and then we'll look at the classification. Quite all right. There are about 5 hypertensive disorders that occur in pregnancy, and I won't go into too much details for each because we don't have much time. We only have maybe about 45 minutes, so we'll just look at them briefly because it's just like an overview that we are looking at. So we'll look at the classification, and then I may pick on maybe 2 where I'll look at even the pathophysiology, and then we'll look at the management for all of them, because for us our main concern is the drugs. So we'll look at how we manage all these 5 hypertensive disorders. So I'll begin by listing them, or maybe before I go to listing them, let me define what these hypertensive disorders are. So these are disorders which are mainly characterized by a raised blood pressure of systolic above 140 and diastolic above 90 millimeters of mercury. Yeah, so it's greater than or equal to 140 over 90 millimeters of mercury, and this is like persistently, or mainly concentrate on. And then there's eclampsia, which is a complication of preeclampsia. Okay, and then there's what they call chronic hypertension superimposed with preeclampsia. Yeah, so now you understand these 5 hypertensive disorders in pregnancy. You understand them very well, and it will be very easy for you to explain them when you begin with preeclampsia, because you find that most of the drugs that you use in preeclampsia, you find that even in eclampsia, some of them you use them. Even in chronic hypertension, some of them you use them. So I'll begin with preeclampsia. Okay, so how we define preeclampsia? There are certain key features which you need to look at. So one of them is that it should occur at 20 weeks of gestation. So if it occurs before 20 weeks of gestation, then it is not preeclampsia. Okay, so it has to occur at 20 weeks or maybe after 20 weeks. Okay, that's one of the features which qualifies preeclampsia. The other one, the major one, there has to be protein in urine. The urine which has been collected over 24 hours. Okay. Then the other one, so there has to be protein in urine. So the protein in urine has to be at least 2 to 3 plus. If it goes above 3, if it goes to 3 plus or above 3 plus, then it is severe, because preeclampsia can be mild preeclampsia or severe preeclampsia. So if it goes to 3 plus and above, then it is severe preeclampsia. Then if it's 2 plus somewhere there, it is mild preeclampsia. Okay? And then, so we said it has to occur at 20 weeks. Then there has to be protein in urine. Okay? And then the other feature, you also look at the symptoms which the patient is presenting with. Mainly, usually there will be a severe headache. Then there will be there will be epigastric pain, like pain in the upper abdomen. Then this woman will also present with that thing. Okay, so those are the symptoms which a woman with preeclampsia would present with. Okay, so if it does not occur at 20 weeks, or if it occurs before 20 weeks, that will now qualify to be called chronic hypertension. It means this woman had this hypertension even before they were pregnant. Okay. Then the other feature is that with preeclampsia is that after delivery, it like subsides. It subsides. It clears on its own. No wonder they say, you know, the solution for preeclampsia or eclampsia is delivery. That's the ultimate solution. So with preeclampsia, once a woman delivers, then it clears off. Okay? Yeah, so that is with preeclampsia. Then one of the major complications of preeclampsia is eclampsia. So no wonder I was saying it's important you start with preeclampsia, because if eclampsia, it like moves from preeclampsia to eclampsia. So now, how do we differentiate the two between preeclampsia and eclampsia? So a woman that has preeclampsia, the woman that is presenting with protein in urine, they are presenting with a blood pressure that is greater than 140/90. Then they are also presenting with the symptoms that I mentioned. If they are not managed, you find that they will go into eclampsia. And the eclampsia, the main definitive term of eclampsia is seizures. So if this, especially the severe preeclampsia, if it is not managed, a woman will start fitting. Okay? And that is a very severe form of preeclampsia. If it is not managed, a woman can die. Okay? A woman can give birth to a stillbirth, the baby can die. Then it can also damage the brain, because those spasms, they tend to affect the vessels in the brain, the vessels. So it will cause like spasms there, which will cause what they call ischemia, that there won't be blood supply to the brain, and that's how brain damage can come in. Yeah. So a woman can die, the baby can die, or there can be brain damage. Then there can also be other organs, they can be damaged, like the kidneys, they can be damaged. The liver can be damaged, because a woman that has eclampsia or preeclampsia, if you do the liver function test, you find that the liver enzymes, they are elevated. The glomerular filtration rate is also affected, so that it can also lead to kidney damage. So this also differentiates other hypertensive disorders from eclampsia and preeclampsia. With eclampsia and preeclampsia, the other organs are also involved. So this is now important as you are doing investigations for eclampsia. You need to check also the liver function, you need to check the kidneys, because they can also be affected. There can be also pulmonary edema, so all those have to be done. Then also the platelet count also has to be checked, because there can also be what they call hemolysis. So the platelet count can also go down, which is called thrombocytopenia. Okay, yeah. So those are the investigations that have to be done. So our main concern for us, being pharmacy personnel, is the drugs. Okay, so that's where I want us to concentrate the most. How do we manage preeclampsia? How do we manage eclampsia? Okay, so maybe before we go to the management of eclampsia, let me also quickly just explain on the other types of the hypertensive disorders. So I've explained on preeclampsia. I've also explained on eclampsia. Okay. So I also briefly mentioned about chronic hypertension in pregnancy. So the chronic hypertension, like I mentioned in pregnancy, it occurs before 20 weeks of gestation. So it means this woman had the hypertension even before they were pregnant. So with chronic hypertension, what you do, You just need to look at the medicines or the drugs which this pregnant woman was taking before she was pregnant. You need to revisit these drugs, okay? Because there are certain drugs which you will find this woman maybe could have been taking, like enalapril or atenolol, and they are contraindicated in pregnancy. So you need to change the regimen of the drugs which the woman will now be taking since she's now expecting. Okay, so that's how we differentiate the management between chronic hypertension and preeclampsia and eclampsia. Then with gestational pregnancy, gestational hypertension, which is hypertension in pregnancy. With gestational hypertension, what you do, because this one, it also occurs at 20 weeks of gestation, just like preeclampsia. But this one is pregnancy induced. So this woman was not hypertensive when she was not pregnant, but she now becomes hypertensive because of the pregnancy. So it occurs beginning from 20 weeks of pregnancy. Okay? But when you check the urine, there's no protein in the urine. No protein in the urine. So this one now, it won't qualify to be preeclampsia, so it will be called gestational hypertension. So with gestational hypertension also, the drugs that you use are similar to the ones you're going to use in preeclampsia. Okay, but with preeclampsia, you find that there will be a point where you're going to be using magnesium sulfate. But with gestational hypertension, you find that you may just be using methyl-dopa and nifedipine. Okay, so that's the differences in terms of management. I'll look at the management condition by condition, but I just wanted us to have an overview. Then there's the one I mentioned, chronic hypertension superimposed with preeclampsia. So this is a woman who was hypertensive even before they were pregnant, but when they become pregnant, you find that in addition to the hypertension that they have, now protein also starts appearing in the urine. Okay, so one may ask, where is this protein coming from? Okay, you find that even preeclampsia, there's what they call trophoblast invasion. When a woman falls pregnant, there's that stabilization of the placenta, the attachment, then there are certain cells that get to be produced, which will be controlling the vasculature in terms of blood supply. So you find that there's a disturbance in the placenta, in the endothelium there. So you find that there will be attack to the endothelium, then it will start like shedding off the membranes, and that's where the hemolysis will come from, and that's where you find now protein starts leaking into the urine. Okay, so now somebody who was hypertensive even before they were pregnant, you find that eventually they start also showing protein in the urine. That is the one they are calling now chronic hypertension, which has been superimposed with preeclampsia. Okay, so that one also you need to revisit the drugs which the woman was taking before she was pregnant. Yeah, then you add those that are suitable in pregnancy, and then you also need to add on other drugs. Okay, so now I want to go to the core part of the presentation, which is the management of these conditions. Okay, how do we manage these hypertensive disorders? Because that's our interest as pharmacy personnel. Okay, so I'll start with preeclampsia. Okay, we've already looked at the definition. I've briefly explained how it comes about. Now, how do you manage it? How do you manage? The woman is coming with there's protein in the urine, the blood pressure is above 140/90, and then they are presenting with all these symptoms. So I'll start with mild preeclampsia. Mild preeclampsia, how we can differentiate it from severe preeclampsia. With mild preeclampsia, the BP is between 140/90 to 160/110. It shouldn't be above 160/110. So it's falling between 140/90 to 160/110. That's mild preeclampsia. Then with severe preeclampsia, over 110 and above. So the moment it's 160/110 and above, you've gone to severe preeclampsia. Okay, so the management is different. So with mild preeclampsia, you're only going to use, you can start a woman with nifedipine. Okay, you can combine it with methyl-dopa. Those are the two drugs that we use. But again, even if it is mild, sometimes you may find that quite alright, it's mild, it's falling between 140 to 160, or over the diastolic 90 to 110. But the symptoms of severe preeclampsia are there. Then in that case, you have to add on magnesium sulfate. Okay? Because if this mild preeclampsia is not managed, it will go into the severe form. And from the severe form, it will go into eclampsia where the woman starts fitting. Okay, so the moment the woman begins to fit, it changes from pre-eclampsia to eclampsia. The moment you just notice my feet, then it's eclampsia. And you have to deal with it severely. Okay, hydralazine injection, you use magnesium sulfate to stop the fits. Okay, but we are still on mild first. I just wanted to make a clear distinction. So in mild, like I said, we are using methyl dopa and we're using nifedipine. So you can use from between 250 milligrams to 1000 milligrams 3 times a day. Okay? So you'll be changing the dose depending on how the woman is responding. So 250 milligrams to 1000 milligrams 3 times a day. So you can give 500 milligrams TDS, you can give 250 milligrams TDS, depending on the severity. Then you can go up to maximum of 1 gram TDS. Because in 24 hours, the maximum dose for methyl dopa, it's 3 grams, which is 3000 milligrams. That's the maximum in 24 hours. So you cannot go beyond that. Okay? Because you go to that, actually a woman, even the side effects of methyl dopa will start presenting like drowsiness, headache, you know. So depending on how the BP is, that's the range of methyl dopa. We ask, because we are concentrating on the drugs, that's our interest. We'll also look at maybe the mechanism of action. How does methyl dopa work? So methyl dopa is a prodrug. That's one thing you should know. It is a prodrug, so it has to be converted to the active form. The way it is not active. So when you take it in the body, it is converted to the active form, which is called the methyl alpha norepinephrine. That is the active form of methyl dopa. So how it works, I'm sure we all know norepinephrine, which is produced in the body, yeah? which works like adrenaline, and we know adrenaline or norepinephrine, they constrict the blood vessels, causing blood pressure to go up. So now, how this methyl alpha norepinephrine, the active form of methyl dopa, how it works, it provides a negative feedback mechanism. Okay, so when it is there in the blood, the body will think, because it works like norepinephrine, which is endogenous in the body. It is produced in the body, norepinephrine. So the body will think like norepinephrine is already there in the blood. Norepinephrine, no wonder I was saying it provides a negative feedback. So when the body stops producing norepinephrine, which we said it constricts the blood vessels, so meaning that constriction will reduce. Because that force a neurotransmitter, the active form of methyl dopa, it is present in the blood, so the body stops producing the chemicals that constrict the blood vessels. Hence, the blood vessels will dilate. That's how methyl dopa works. Okay? So we've looked at its mechanism of action. I've mentioned the side effects: drowsiness, headache, dizziness. Then we've also looked at its maximum dose and how you dose it. That's methyl dopa. Okay? So that's number 1 drug we give in pregnancy. In a pregnant woman who's hypertensive. Okay? Then let's go to severe preeclampsia. So with severe preeclampsia, we'll say this one, it's above when you check the blood pressure, the systolic is above 160 and the diastolic is above 110. Okay? So that's severe. So with this form, you are still going to use dopa and nifedipine. Nifedipine, the dose, you can give 20 milligrams once or twice a day. In severe forms, you can even go to 40 milligrams once or twice a day. So the maximum dose for nifedipine in 24 hours, in pregnant women that are hypertensive, it's 80 milligrams. So I wonder when you see a prescription for 40 milligrams BT nifedipine, don't be shocked. The maximum in 24 hours is 80 milligrams. It's 80 milligrams. Then the mechanism of action, I'm sure we all know, it blocks the calcium channels. Then there are different types of calcium channels. So this one particularly, it blocks the L-type calcium channels. Hence, it inhibits the influx of calcium ions. Okay? Once those calcium ions, it blocks that the action potential, hence there will be relaxation of the blood vessels, the blood pressure now going down. So that's the mechanism of action of nifedipine. Then we looked at its dosing, the maximum dose also. Yeah, so in the severe form, like I said, if you notice other symptoms are also there, like the 3+ protein in the urine, then there's the nausea, the woman is having a terrible headache, there's the abdominal pain, then you know that this preeclampsia is highly likely to go into eclampsia. So that, in that case, you are also going to give magnesium sulfate. Okay? So the one, on the magnesium sulfate, that's where I want you to understand it the most. If you don't give magnesium sulfate in a woman that is presenting with severe preeclampsia, it is highly likely to go into eclampsia. So you have to prevent it by giving magnesium sulfate. Okay, so we'll look at magnesium sulfate just like we've done with the other drugs. So we need to look at how it works, we need to look at the dosing, we need to look at the maximum dosing also in 24 hours. Yeah, so I'll start with the dosing, because this one actually it's a bit tricky. A lot of people make mistakes, they end up underdosing. So you have to give the start dose of 14 grams for magnesium sulfate. 14 grams. I don't know the one we have. Is it a 1 gram? The one we have in stock?
Which one?
It should be a 1 gram, the one we have. So you have to give 14 grams start. Then you'll be giving 4 dose. So how you give this 14 grams? See? You give it this way. 4 grams, you give it as IV. Okay? You give it as IV, and you use 20% of it, because it comes as, you can dilute it as 20% or 50%. So you give the 4 grams as IV, you give it slowly, over 5 minutes. Okay? Then the other 10 grams, the way you're going to give it, 5 grams, you give it as, the other 10 grams you give it as IM, but you're not going to give it like yours, 10 grams you push. So what you do, the 5 grams, you push in one bottle, IM. Remember the 4 grams you gave it as IV. So the 5 grams you give on one bottle, IM. Then the other 5 grams again, you give promptly. Like the moment you pass 4 grams IV, then you also start giving the 10 grams. Like you give IV 4 grams, then on one bottle you give 5 grams, and on another bottle you give 5 grams. IM, that is. So that gives us 14 grams. That's a start dose of magnesium sulfate. Then you need to make a clear distinction. The one we are giving IV and the one we are giving IM has to be 50%. They are different. Okay, so if you only have 1%, then you need to do the dilution. So that you come up with a 50% and you come up with a 20%. So that's how you give as a start dose. So don't supply magnesium sulfate. They don't have anything completely. You just give them 2 vials. You're not doing anything. Those seizures will not stop. You need to know how much is this patient supposed to be given. How much am I supposed to supply? Okay? Then the maintenance dose, you have to be giving every 4 hours. And how you give, you continue that when you're giving in the bottle, 5 grams. So every 4 hours you'll be giving 5 grams. If you give on one side this time, the next time you give on the other side. Every 4 hours until the seizures they stop. So if the woman continues fitting, you'll be giving every 4 hours. But once they stop, then you are going to discontinue. Yeah, so that's how you give the magnesium sulfate. Yeah, and then the mechanism of action, it's not, but some books say it has 2 mechanisms of action. One of them is that it blocks the action potential because of the magnesium ions. Hence stopping the contraction of muscles, those rapid contractions which leads to fits. Then the other mechanism of action is that it relaxes the blood vessels also, leading to reduce the pressure. So 2 mechanisms, it inhibits with the transportation of the calcium ions, so it has a similar mechanism like in nifedipine. Then the other mechanism is that it blocks the action potentials, like the way the epileptic drugs work. They block the action potential, hence to stop those spasms of muscles, which leads to seizures. Yeah, so that's about the magnesium sulfate. So that's the key drug in severe preeclampsia and in eclampsia. Because like I said, you don't give that, then the seizures will continue, and the baby may die, or the mother herself will die, or it will cause brain damage, or it will damage other organs like the kidneys, the liver, Yeah, so that's the management of preeclampsia and eclampsia. Then the other drug I almost forgot to mention, which you need to give in severe preeclampsia and in eclampsia itself, is hydrolysis injection. So you just, that magnesium sulfate we're giving to stop the seizures, but we need to reduce the blood pressure as well. So you are also going to give hydralazine, and you give it as 5 milligrams IV. Okay, you give it over 5 minutes. In case you see the blood pressure is not reducing, because our target for us to give hydralazine, we want to bring that diastolic blood pressure, which is 110. We want to bring it below 110. So if you give 5 milligrams of hydralazine, the diastolic has not come to below 110. You have to give again after 30 minutes until it comes in below 110 millimeters of mercury. Then you can discontinue and continue with the other drugs. Yeah, so magnesium sulfate, very important. Hydralazine, very important. So these are drugs, if you're looking at drugs that are to be stocked for maternity, these are the key drugs we need to have. Yeah, because actually preeclampsia has been classified as 3 causes of maternal mortality. So a lot of women die from this condition if we don't have these 2 drugs. So we need to have them like all the time as pharmacists. Yeah. So this, this is why we want to be having this presentation, so that we know what does this drug do, how important is it, yeah, how much of it are we supposed to have. Yeah, so that's about preeclampsia and eclampsia. Then with chronic hypertension, how you manage it, like I said, this woman had the hypertension even before they became pregnant. Okay, so there are drugs which they were taking already. So you just need to look at what drugs were they taking. Are these drugs safe in pregnancy? Should they continue with these drugs? So for instance, if they were on enalapril, you need to discontinue it. We need to commence them on aldomates, and I already gave the dose. You can give from 250 up to 1000 milligrams TDS. You need to introduce methyl-dopa. Then if they were on atenolol, also you need to discontinue, because these 2 drugs, you find that they affect the blood supply. So they cause what they call growth restrictions of the fetus because of the reduced blood supply to the fetus. So this should not be given in pregnancy. Enalapril, atenolol should not be given.
Under atenolol, we can give labetalol.
We can give labetalol. Thank you so much. Yeah. Yeah. So even when we were looking at preeclampsia and eclampsia, where we were using methyl-dopa, or where we were using nifedipine, the alternative drug we can use is labetalol. Yeah. So I think it's the only beta blocker that can be used in pregnancy, labetalol. And the reason is this one is a non-selective alpha-adrenergic blocker. So it blocks both the beta receptors and the alpha receptors. But with the alpha, it is selective for alpha-1. Then for the beta receptors, it blocks both beta-1 and beta-2. So because of the selectivity of blocking alpha-1, it compensates for that other effect which is caused for like atenolol. So no wonder it is safe. Yeah. So that's its mechanism of action. It blocks adrenergic alpha and beta blockers non-selective. Yeah. Then it can be given 200 milligrams to 400 milligrams BD. Although here I doubt if we've ever stopped it. UTH once in a while they do stop it. Yeah. Yeah, so then another period we need to discontinue. Atenolol you can discontinue and introduce things like nifedipine, you can introduce aldomate, you can introduce labetalol. Yeah, that's for chronic hypertension. So it's easy. That's why I started with preeclampsia, because you find that the drugs that you're using there, they are the same ones that you're going to use for the other conditions. Yeah. Then for gestational hypertension or pregnancy-induced hypertension, it's the same drugs. You can still use aldomate, you can use nifedipine, you can use labetalol, depending on how the woman is presenting. Yeah. So that's about the management of these disorders. I think this is where I'll end. Unless if there's something I've left out, feel free to add. Or maybe the risk factors. I didn't tackle the risk factors. Causes a woman to have preeclampsia. So we look at the age. A woman that falls pregnant, that is above 35, there's a high risk of having preeclampsia. Then also falling pregnant at a tender age, like below 18, it also increases the risk of somebody having preeclampsia. Yeah, so that's one of the risk factors. Then the other one is if somebody has a history of preeclampsia, like they had preeclampsia in the other pregnancy, then they are highly likely to have it again in the next pregnancy. Yeah, and then the other risk factor we could look at also family history. If there's somebody who's got hypertension in the family or somebody who had preeclampsia, it also predisposes you to have preeclampsia. Also weight gain. Somebody who's like obese or overweight, they have high risk of having preeclampsia. I think that's what I left out in my presentation. Yeah. So I'll end here for now.